Down syndrome is one of the first developmental disabilities to be recognized as a syndrome. It was identified by Dr. Langdon Down in 1866. Today, it remains a common cause of intellectual and physical disability in infants. Initially, this condition was diagnosed solely through physical traits. Down syndrome occurs when a person has an extra copy of chromosome 21. This extra genetic material affects development, leading to physical traits and developmental delays. There are 3 types of Down syndrome. Trisomy 21, where all cells have an extra chromosome 21, is the most common type. Mosaic Down syndrome, where some cells have an extra chromosome while others do not. Translocation Down syndrome, where a part of chromosome 21 attaches to another chromosome. Although Down syndrome is a lifelong condition, early therapy and support can greatly enhance independence and skills. People with Down syndrome often have distinct physical features, including a flattened face, upward slanting eyes, small ears, short stature, and a single crease in the palm of the hand. They may also experience developmental delays, such as slower progress in speech, learning, and motor skills. Certain factors increase the chances of having a baby with Down syndrome. Maternal age: the risk increases as women age, especially after the age of 35. Family history: while rare, Down syndrome can be inherited if a parent is a carrier of a genetic translocation. Down syndrome is the most common chromosomal condition, affecting about 1 in 700 babies worldwide. This condition occurs in people of all races and backgrounds, highlighting its global significance.
Hypermetropia, moderate to high astigmatism, and oblique astigmatism are more prevalent, often increasing with age due to a failure of emmetropization, the eye's natural process of adjusting its focus during development, often developing after 6 months of age. Esotropia, an inward turning of an eye, occurs in up to 70% cases. This can range from accommodative to non-accommodative type, with varying impacts on vision. Arrhythmic eye movements, nystagmus. Present in 5 to 30% of the children, while it's often less noticeable in early life, can occur alongside esotropia and affect stability and focus. Particularly congenital nuclear types affect 11 to 50%, vary in size and density, often requiring early intervention to prevent visual impairment. Insufficient accommodation may affect up to 80% of children and adolescents. This leads to poorer vision at near distances compared to far. Even with glasses, many struggle with near tasks due to accommodative anomalies, not early presbyopia. A condition affecting up to 18% causes thin corneas and severe astigmatism, often presenting as corneal hydrops in adolescence. An inflammation of the eyelids occurs in 10 to 81.9% due to poor immune function, leading to discomfort and recurrent irritation.
Children with Down syndrome may have delayed growth, distinctive facial features, and poor eye contact. They often have refractive errors, causing reduced visual acuity. Down syndrome children have a high prevalence of refractive errors, which include hyperopia, myopia, and astigmatism. Hirschberg test, cover test, and prism cover test predominantly identify esotropia in Down syndrome children. Slit lamp examination frequently identifies keratoconus, congenital cataract, brushfield spots, blepharitis, and nasolacrimal duct obstruction in Down syndrome children. Optic nerve hyperplasia and other retinal abnormalities may be observed during binocular indirect ophthalmoscopy. They commonly have reduced stereopsis or absence in depth perception. Most individuals with Down syndrome have normal color vision, as color blindness is not directly linked to trisomy 21. They often exhibit reduced contrast sensitivity compared to typically developing peers. During visual perception test, they may present a delayed visual processing, weaker spatial awareness, reduced fine motor coordination, difficulty with visual discrimination, and variability in visual memory.
Now, let's talk about eye treatment and management in children with Down syndrome. Did you know that they often face unique vision challenges that require specialized care? Now, let's break it down. First, let's talk about refractive error. Many children with Down syndrome need glasses earlier than typical children. Regular checkups ensure their vision is clear and properly corrected. Next, accommodation is one of issues are common too. Bifocals are recommended to help with both near and distant vision. They are fitted with a segment top at pupil level to make reading and focusing easier. However, progressive lens can sometimes cause peripheral distortion, so their adaptation needs careful monitoring. Strabismus or misaligned eyes is also frequent. For hyperopia or focus issues, glasses are often enough, but if not, eye muscle surgery like medial rectus recession might be needed. Head tilt dependent esotropia can be managed with patching or prisms, but surgery might be the solution in severe cases to improve alignment and posture. Moreover, cataracts are serious and can lead to amblyopia or lazy eye. Surgery is often necessary, followed by careful monitoring for complications like glaucoma or retinal detachment. After surgery, optical correction is vital. Nystagmus or involuntary eye movement must be addressed seriously. Support from visual impairment educators and neurologic evaluation for acquired cases are crucial. On top of that, preventing eye rubbing is key to managing keratoconus. Glasses or contact lenses help with vision correction, but for severe cases, advanced treatments like collagen cross-linking or cornea transplants are available.
Next, let's take a closer look at the incredible team of specialists who work together to provide the best vision care for these children. A pediatric ophthalmologist is at the center of vision care. They perform comprehensive eye exams, diagnose conditions like strabismus, cataracts, or keratoconus, and provide both medical and surgical treatments when necessary. Next, the orthoptist. They specialize in treating eye movement disorders like squint strabismus and lazy eye amblyopia. Through exercises and therapy programs, they help improve how the eyes work together. When vision impairment significantly affects daily life, a low vision specialist steps in. They provide tools like magnifiers or adaptive devices to help maximize functional vision. Moreover, an occupational therapist who focuses on visual therapy helps children integrate their vision with motor skills. This support improves activities like handwriting, reading, and playing. Special education teachers or visual impairment educators play a crucial role in schools. They ensure children with Down syndrome and vision issues have access to adaptive learning tools and a supportive educational environment.